Hello guys, welcome to the next video series of intrauterine fetal death. In last video, I have discussed about the recommended evaluation in case of the IUD. In this video, we will further discuss about its complications. So let's start. So there are several complications that we met around in case of the intrauterine fetal deaths. So first one is the psychological upset. In case of IUD, it often becomes a problem. In the mother, they generally feels that my baby is died, and in family they also are upset. Second one is the infections. So in case of the IUDs, as long as the membranes are intact, infections is unlikely. But once the membrane ruptured, infections, especially by gas forming organisms like the Clostridium welchii, may occur. The dead tissue favors their growth with disastrous consequences. So infections are the second complication that might occur. Third one is the blood coagulation disorders. Though they are rare, but if fetus is retained more than 4 weeks, in case of the around 10 to 20% of cases, there is possibility of defibrillation from silent DIC, disseminated intravascular coagulopathy. So the DIC is due to the gradual absorption of the thromboplastin, which is liberated from the dead placenta and decidua into the maternal circulation, and the DIC occurs in the maternal blood, and the consequences are disastrous. You have to manage patients very actively, otherwise it can lead to the death of the mother also. But these cases are rare. Fourth one is the during labor there may be uterine inertia, which itself a topic to be discussed. Second is retained placenta and the PPH. So these are the some complications that you face in case of the IUDs. Now the management. So guys, in the management part, the prevention is very much important. The overall risk of recurrence of stillbirth varies between 0 to 8%. The conditions that run the risk of recurrence are hereditary disorders, diabetes, hypertension, thrombophilias, placental abruption, and fetal congenital malformations. These are cases in which there are risk of recurrence. So the IUDs cannot be totally prevented, but following guidelines may help to reduce its recurrence. So first is preconceptional counseling and care. It is very essential to prevent its occurrence in the higher risk group. So guys, avoid this small spelling mistakes. So let's go further. So first one is the preconceptional counseling and care. It is very essential to prevent its occurrence in the high risk group. So what are the high risk group? I will post on another post that which are the high risk groups. Also I have already discussed these are the cases where recurrence are occur. Also they are the high risk groups. So second one is prenatal diagnosis. By chorionic villus sampling or amniocentesis, in the selected cases we can side the high risk group and we can manage the patient better to avoid the IUDs. Third one is to screen the mother at risk during the antepartum care, and the careful assessment of fetal well-being and to terminate pregnancy with earliest of fetal compromise. So during the antenatal period we have to screen the patients who are at the high risk and also assess the fetal well-being, and if we found any high risk cases we have to terminate pregnancy earliest if possible. Next point is the breaking the bad news to the mother and the family member is very difficult. mainly due to the poor outcome and for medical legal problems. So, to answer this problem, we have to first listen to the patients and family members actively and then to answer their concerns. Concerns are important. These needs professional skill and abilities. So breaking the bad news by an intern is not as good as the PG, and the breaking bad news by PG is not as good as consultant. So this is the it needs professional skills and abilities. Now in the management part, second one is the expectant attitude. The patients and the relative are likely to be upset psychologically, but they should assured of safety and non-interference. In about 80% of the cases, spontaneous expulsion occur within 2 weeks of the death. But in today's practice, this expectant attitude is not done and we will manage the patient actively. The woman with the intact membranes and no evidence of DIC or sepsis may remain at home with advice to come for delivery at hospital. Fibrinogen level should be done twice weekly. This was done before, currently it is now in practice. So what are the reasons for early delivery? Reliable and early diagnosis could be made with the real-time USG. Prostaglandins are available for effective induction and complication could be avoided. These are the reasons for early delivery. So what are the indications for early interference? Psychological upset of the patient is very common. Manifestation of the uterine infection. Tendency of prolongation of pregnancy beyond 2 weeks. And falling fibrinogen levels. Although they are rare, but these are the some indications for early interference. So now we further move to the methods of delivery. The delivery should always be done by medical induction. So first method is combination of mifepristone and prostaglandins. It is recommended as the first line of induction. In this regimen, the single dose of 200 mg of oral mifepristone is given, and then misoprostol, that is PGE1, is given intravaginally 25 mg 4 hourly are safe, effective and low cost. Induction delivery interval was about 8 hours, but it depends on patient to patients. Second regimen is mifepristone 600 mg is given daily for 2 days alone. In this only mifepristone is given. It's 600 mg, it means 3 tablets are given today and next day 3 tablets are given. This is also a regimen that could be used. In second regimen, only misoprostol is given either vaginally or orally. It is also found to be effective. Vaginal route is more effective compared to oral route, which is repeated 4 hourly, preferred to oxytocin or PGE2, as it is safe, effective and cheap. So prostaglandin misoprostol is given at the strength of 25 to 50 milligram either vaginally or orally. Because it's safe, effective and cheap, it is preferred over oxytocin and PGE2. The third regimen is the prostaglandin PGE2, which is a dinoprostone. Vaginal administration of PGE2 gel or lipid pessary in high in the posterior fornix is very effective of induction where cervix is unfavorable. In cases of unfavorable cervix where Bishop's score is very poor, we can use the PGE2 gel or lipid pessary high in the posterior fornix for induction of delivery. It is repeated after 6 to 8 hours. It may be supplemented with the oxytocin infusion. Fourth one regimen is the oxytocin infusion. When the cervix is favorable, Bishop score is high, around 5 to 10 units in 500 ml RL via IV route is started. In case of failure, escalating dose of oxytocin used on second day, in which there is 20 units of oxytocin in 500 ml RL is given at 30 drops per minute, around 80 milliunits per minute. One should exclude the secondary abdominal pregnancy, hemolysis, and autoimmune hemolysis if repeated attempts are failed to start the labor. Now, there is a patient who has history of previous LSCS, now present with the intrauterine death. How will you further proceed? So, in these patients, the PGE2 gel may be used safely in women with previous one LSCS, but in previous two LSCS, risk of rupture of uterus is slightly more. And place of LSCS in case of intrauterine death is limited. Previous to LSCS or major degree of placenta previa and transverse lie are the rare condition in which you have to do LSCS. These are the recommended dose of misoprostol. This was the previous one recommended dose. Nowadays there is updated regimen which I will upload in the community post. Now, other than delivery, you have to also give postpartum suppression of the lactation, for which the cabergoline, which is dopamine agonist, is given as single dose 1 mg, which is found effective, and it should be given women with PIH or hypertension, which also helps in controlling the blood pressure. Bereavement management and the purpurium. The medical team and nursing staff should provide all the support and the sympathy to the bereavement couple because they are already in such a pain. The couple should explain in simple terms about the possible cause of the fetal death. Psychologist or the counselor may be seen them for a support. They may need a psychological support. Recovery in the postpartum ward is better avoided. They should be provided another room in which they are separated from normal postpartum patients. Postpartum depression is high in these patients, for which the couple is seen in postpartum clinic after 6 weeks. Investigation reports are viewed and counseling of future pregnancy is done. Now, management of the subsequent pregnancy. Correction of non-adverse factor as revealed on investigation for the IUFD should be corrected, preferable before the subsequent pregnancy. Some of the factors that are mismanaged in the first pregnancy that which are reversible, it should be corrected before planning the subsequent pregnancy for better outcome in next pregnancy. Surveillance for the mental health and the fetal well-being are to be maintained very actively. Prenatal genetic diagnosis may be needed in some, or in some cases it may be termination of delivery need at 38 weeks of pregnancy. So here we conclude our intrauterine death topic. If you find any error or problem, do comment down below, and also if you are having some suggestion, also tell what could be improved, and also comment down on which topic you need next topic videos. Thank you.